Welcome to the Office Hours Quality Payment Program QPP conference call. My name is Adrian, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we'll conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star, then 1 on your touch-tone phone. I'll now turn the call over to Holly Standard. Holly Standard, you may begin.
Hey, thank you so much, Adrian. Hello, everyone. Again, my name is Holly Standard, and I'm a Quality Program Manager with Lake Superior Quality Innovation Network, and we serve Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to the session of the QPP office hours for June. And so today's call, it will be operator assisted. And by default, again, everyone's phones are currently muted to avoid background noise. And since this is an open office hours call, there will be opportunities to ask questions over the phone, at which time our operator, Adrian, will provide instructions. We will also be closely monitoring the chat box and encourage you to post questions or comments throughout. Also, please note that the information provided during the session is based on the latest information made available by CMS and is subject to change. And as CMS policies change, we encourage you to review specific statutes and regulations that may apply to you for interpretation and updates. And at the end of the office hours, you'll have an opportunity to complete a brief evaluation. We would also appreciate your feedback about this event and suggestions for future educational sessions beyond the Quality Payment Program office hours. We'd also like to remind you of those that receive direct technical assistance related to QPP. If you could please take time to complete the evaluation sent at the conclusion of each technical assistance encounter. The feedback is very valuable to us and allows us to gauge how we are doing with meeting your information needs in a timely and courteous manner. Also, I would like to mention that during the office hours call, we typically can address a broad range of questions, which are based on equally broad range of QPP MIPS knowledge. And some of these questions we'll be able to answer quickly. Others may require some additional time to research, so due to the complexity of that question. And others will be specific to your organization. And our team is implementing a process to capture all of those Q&A questions that have been presented during this call. And after this call, we will take a look at those questions and see which ones are broad and applicable to the audience and email participants within 2 weeks of that information. So you have a nice reference document. So again, finally, any questions that require more research or those that appear frequently will be addressed at the next office hours as well. So thank you so much, and we will begin with our updates for our monthly topic. So a couple of updates that have occurred, and this is just a reminder for this year. So 2018, the Quality Payment Program reported started on January 1st. And 2 of the categories, the quality and the cost category, are required to be reported for a full year, whether you're in a MIPS program or a MIPS Alternative Payment Model. Improvement activities and the new promoting interoperability, or renamed from advancing care information, those can still be reported at a minimum of 90 days. Additionally, towards the end of July, there's going to be feedback reports that will be available for the 2017 Quality Payment Program submissions. Those reports are Quality Resource Use Reports, or also known as QRURs. For those that have an EIDM account, the Enterprise Identity Management account that was used to set up the Quality Payment Program attestation, those users will be receiving those QRUR reports. So again, those reports will show you your QPP submissions and how you fared out within the program, and those will be available toward the end of July. Also, too, for 2018 eligible clinicians, on the qpp.cms.gov website, the 2018 participation status link has been updated. And that will allow clinicians to look at their status, current status for Quality Payment Program reporting for 2018. Also, CMS has just recently added the MIPS Alternative Payment Model to that link. So if you go to the qualitypaymentprogram.cms.gov, if you click either under MIPS or under APM, you can check your 2018 participation status. Keep in mind that this participation status has the potential to change depending on the snapshot periods that are associated with alternative payment model reporting. So make sure that you keep an eye on that status throughout the year. So I don't have any other updates for the Quality Payment Program. So at this time, I'd like to open up the forum for our attendees to ask questions. So Adrienne, if you can open up the line.
Thank you. We'll now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There'll be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have an audio question, please press star, then 1 on your touch-tone phone. And as a reminder, to enter the queue, please press star 1.
This is Holly again. So I'd like to start. I did receive some emails regarding some questions from those who had registered for the event. So I'll start with a question that we had received, and this is by Noreen. Noreen had asked, is the cost category included in the Quality Payment Program reporting for 2018? Noreen, yes. The cost accounts for 10% of the final MIPS score in the reporting year 2018. And also eligible clinicians who do not submit any additional information since the measure is calculated by claims, and it is dependent upon the measures that you submit for the quality category. So thank you so much, Noreen.
Oh, yeah. And Holly, this is Candy with Stratus Health, and maybe we want to just do a little bit more, say a little bit more about that. So for 2018, the cost category is 10% of the score, of the 100-point score for 2018, but it is set to go to 30%. And the two measures that are measured for the cost category are Medicare spending per beneficiary and total per capita cost. And so you'll be getting more information about what that looks like on the Quality Resource and Use Report, I believe. Isn't that right, Holly and Mona?
Yes, that is correct, Candy.
That's correct.
We do have a question in the queue, but they didn't leave a name. Go ahead, your line is open. If you could say your name. Hello, you press star 1 to enter the queue.
Hi, this is Don with Healthies. Can you hear me?
Yes, we can.
Great.
Hi, Don.
Hi, Candy. How you doing? A couple of questions for you. Just some insight on your perspective, please. Have you heard anything new about the proposed 2019 ITPS rule and kind of a general timeline? It's my understanding any comments we have are due by the 25th, but after that, do you have a general feel for when we might hear back on that feedback and when they're going to finalize that rule? Also on information prevention blocking and any proposed rules to change macro MIPS for eligible providers yet this year?
Go ahead.
Hi, hey, Don. So we have not. We are expecting the proposed rules, or the proposed final rules for 2019. We're hearing that they're supposed to be coming out any day. We have not heard anything. I have not, anyway, heard anything more specific than that. I don't know if you guys have heard anything more specific, Holly or Mona?
No, I have not. This is Mona.
And this is Holly. Yeah, just some general information, not really in-depth as to what Don was looking for. So hopefully we get some clarity shortly.
Yeah, and I haven't heard anything more about information blocking yet either, Don, but I would imagine, since it was written into the 2017 final rule, I just believe that there will be information in that proposed final rule that will have information about information blocking, but otherwise I've not heard any updates about that. How about you guys?
The only thing that I have heard on that is that they were trying to make the verbiage more clear when people are attesting to it, but other than that, I have not heard a thing.
Would you
there was some confusion when people attested to that the first year.
Would you suspect that that rule will also give us a little bit better definition of what information we need to collect to demonstrate compliance?
Yeah,
I would hope so.
Yeah, I would sure hope so too. But isn't that the $1 million question, Don? Because it's like, it would be so helpful if you could provide us with some very specific guidance on that. Mm-hmm. It'll be interesting to see, though. I mean, we haven't seen very specific language in the last two rules, just in terms of auditing or, anything like that. So, and I really I'm starting to hear, rumblings about getting ready for audits, but I have not heard anything more specific than that. So, okay. I hope they do. I sure hope they do, Don.
Since I'm on the line, can I ask another unrelated question to these?
Absolutely.
Okay. Last year, we were really challenged with trying to understand who CMS recognized as providers within our ACO. Just kind of curious what the timelines would be for this year to submit the providers that should be part of our ACO and when there will be a cutoff date so that, say again, after October 1st, they don't recognize these providers as part of our ACO, therefore we don't have to attest for them. Are you getting a feel for what the timelines are for when we need to provide a final list of providers that CMS would recognize as being part of our ACO membership?
Yeah, this is Candy. I have not heard anything else, but Don, that's something that we could do a little more research on and see if we can't get an answer to that.
That would really be helpful because it was so gray last year and never really knew which providers CMS recognized as part of our ACO and which they did not. So anything that you could provide would be very helpful.
Sure. And Don, did you say the cutoff date for last year was October 1st?
It seems to me that they didn't really mention that until like around February, that they didn't recognize anybody after October 1st. So
that's right. Yep.
So, Don, this is Lisa.
Yeah.
And so I was on an APM conference call yesterday with CMS, and they're going to add this year December 31st deadline for anybody who's joined your organization after August 31st, and that you can, I think they're going to be setting up those guidelines, so it will be different than they did it last year.
Okay. So
but Lisa,
clarify that, Lisa?
Oh, Lisa, I thought this is Candy. I was on the same webinar, and I heard that to be only for MSSP for shared savings. Did you hear that differently, Lisa?
We can clarify that. I was thinking it was for advanced APMs, but let's clarify. I know that they are working on it, and we're waiting for more final language on that. But if it's specific only to MSSP, then we'll find that out.
Yeah, because that's what I wrote that down, that the fourth snapshot was only for shared savings program, okay. But I could have written it down wrong. I could have heard it wrong, but we'll clarify that for sure, Don. And I know you had a follow-up question for Lisa.
Yeah, so just for clarification, if it is just MSSP, which we still may be part of this year, what do you think the dates are going to be?
Well, August 31st is your last date that to have people on your participation list. But if you have somebody who's joined, they take another snapshot, and you're right, Candy, I think it is just for MSSP to have people added on to your list. So I don't think the details are out about that yet.
Okay.
But
yeah, Don, they added, so for the shared savings program, they added the fourth snapshot date this year, which is December 31st.
Okay, so if we have new providers that start between August 31 and December 31, they would be included in that December 31 snapshot?
That's my current understanding, Ben.
Okay. All right. Thanks a lot.
And I believe that's only for, of course, MSSP is only for group reporting. So the issue with that is that you, in order to be in a APM, you have to start reporting quality of January 1st of this year. So that aggregate data could be used for that provider who joins later. But more details to follow, I'm sure.
And as a reminder, to enter the queue, please press star, then 1 on your touch-tone phone. Standing by for more questions. And we have no further questions.
I'm going to address Don's question about the specifications for the direct. There is a new specifications for promoting interoperability on the QPP website. One of them is ONC Direct Review Attestation. And it says in the details of that specification files per measure will be available summer of 2018. So I'm thinking with the specification files for this ONC Direct Review Attestation should be available sometime this summer on this attestation measure.
And as a reminder, to enter the queue to ask a question, please press star, then 1 on your touch-tone phone. Still standing by for questions.
This is Holly. I wanted to also point out for anybody who has recently visited the Quality Payment Program website, if you were having issues with accessing the quality measures, they have now corrected that, and you should be able to see quality measures related to MIPS reporting.
And we have no questions at this time.
And Holly, I didn't remember if you said this and I just didn't hear you. I apologize. This is Candy again. But I did want to just remind people that the scores that you might be seeing in the QPP portal at this time are not final. They're still putting in the exceptions and the HSA designations and some of the other things. So just to remind people that if you've looked at your preliminary score, just to remind you that that is not your final score, and it may indeed be adjusted by the time we get to next month.
Thank you, Candy.
And currently we have no questions. This is the operator. I just want to confirm you guys can hear me.
Yeah, we can hear you, Adrienne. Thank you.
Okay, thank you.
I did receive another question during the week I'd like to share with everybody just as a reminder. One of our practices we work with, Tabitha, I don't know if she's on the line, but she had asked me if you use the same reporting time frame for each of the MIPS categories. Similar to how it was in 2017, basically, answer is no, essentially to ease the burden of reporting. And to allow for flexibility, the reporting periods can be different. But keep in mind, 2018 is a little different. So quality and cost are reported for a full year. So there's no calendar year. So there's no flexibility in switching those time frames around. However, when it comes to the promoting interoperability and also the improvement activities, you can use different 90 days if you're reporting a minimum of 90 days. So, for example, if you wanted to use the first 90 days as you're promoting interoperability and the last 90 days for your improvement activities, that is still acceptable for MIPS reporting for 2018. So, Tabitha, if you're on the line, thank you so much for submitting that question.
And that stands for MIPS reporters, not advanced APM reporters. Oh, I'm sorry.
Stratus Health. I'd like to add something to that if I could. Go ahead, Lisa.
I'm sorry. Scratch my comment. I was thinking a full year for quality reporting, but that's for everyone.
Yeah. This is Reed Haza at Stratus Health. So to add to that comment, one thing that came up last year for the reporting period was if you're reporting as a group and you're picking different time periods, you may have providers within that group that have different start and end dates for 90-day periods. So what CMS advised is when you're reporting on that is to determine what the earliest date is that you're reporting on, whether it's an improvement activity or something within the promoting interoperability category, and then the final date for any member of that group that you're reporting. So if you have variables between providers, just the earliest and latest dates to report.
Thank you, Reed. Adrian, if you could remind everybody how they could ask a question.
Will do. As a reminder, to enter the queue or to ask a question, please press star, then 1 on your touch-tone phone. To be removed from the queue, please press the pound sign or the hash key. Again, to ask a question, please press star, then 1.
Yeah, it looks like I got a direct message from an attendee by the name of Christine. Christine, it looks like you were asking, your practice doesn't have an electronic health record. Does that mean we are exempt from reporting MIPS? So thank you for asking that. So it looks like for 2018, the rules still apply as they did for 2017. So, no, you're not exempt from reporting MIPS. Clinicians can file a hardship exception application by December 31st of this year, indicating that they lack certified EHR technology within their practice. So if it is approved by CMS, the promoting interoperability, or once formerly known as advancing care information, that category will go from 25% of your total score to a category weight of 0% for that category score. But again, it has to be approved. And then also that same 25% that was allocated to was now PI would be redistributed to the quality category. Now keep in mind for 2018, the percentage rate for the quality category has now changed. So instead of it being, I think it was 60% last year, it's dropped down to 50% for this year. plus that additional 25%. So if you add that up, 75% of your total MIPS score would be allocated to quality, again, if you were approved to use the hardship based on lack of cert. So you need to understand that that quality category is going to be heavily weighted on your final score. And then also you will still be required to report for the improvement activities category at 15%, and then your cost category at 10% for reporting your 2018, and that comes up to your final score of 100%. So thank you, Christine, for submitting that question.
Hey, Holly, this is Candy. I wanted to just put a different spin on that question because I have worked with practices that have not had EHRs in the past, and they have been successful reporters. Certainly it was easier when the threshold, when the neutral threshold was at 3 points versus this year when it's at 15. But it is entirely possible for a practice without an EHR to at least be in the neutral category of that 15 points. If you take a look, so first of all, a couple of considerations. If you're small, if you're considered small, so less than 15, you already, and you report on one category, you will receive automatically a small practice bonus of 5 points. So you just get 5 points for being a small practice. And so that means that you need 10 more points. And so if you look at the high and medium weighted improvement activities, medium being 10 points each, and high being 20 points each, and then those are added together because that category is weighted at 15% of the total 100-point score. So look through those activities and see if there are activities that you're already doing or that you think you could do for 90 days in this year. So that's the first way to get your additional 10 points. In addition to that, if you're so if you don't have an EHR, for an electronic health record for your record itself, and you're doing claims, for example, it's entirely possible to find some claims that will get you up to that 15%, to get you up to that additional 10 points, and especially if quality gets reweighted. So you really want to be paying attention to the quality measure specifications that are via claims on the CMS website, and pay attention to the CPT codes and the HCPC codes so that you're making sure that you're coding your claims correctly so that you get credit. But it is entirely possible to reach that 15-point threshold or above and not have an electronic health record.
Thank you, Candy.
And as a reminder to get into the queue, please press star and 1 on your touch-tone phone.
This is Holly again, and this is just a reminder that, again, at the end of July, we anticipate those QR/UR reports to be available. And, that's really just an opportunity to take a look at, your scoring. Now, all things considering, the baseline measurements for the quality measures are going to be a moving target. They're always going to be changing. But at least, the one piece of advice I often give my clinicians is, they ask me how, I should be scoring or what should I be looking for when I'm reporting quality measures. And, your goal really is to get as close to those 10 points as possible. So taking a look at those benchmark reports for the individual quality measures, and if you're consistently scoring, 30 or 40%, that might be somewhat adequate to get, 5 points, but you always want to make sure that you're implementing those workflows and ensuring that you're capturing those measures, and like Candy indicated, taking a look at those specification sheets. Most often, specifications for quality measures often do not change, but sometimes they will, and they might throw in an additional visit code or an exclude a visit code, and you want to make sure to always have your pulse on those quality measures to ensure that you're capturing it for every encounter or eligible encounter.
Yeah, and Holly, I want to just add one other thing. This is Candy again. For the improvement activities, what I didn't say out loud was that you don't need to have an EHR to attest to improvement activities. You just need to, when the portal is open, you just need to go to the attestation, the QPP portal between January and March to be able to say that, yes, you indeed have done that improvement, those improvement activities.
That's a good point, Candy, and also, too, for our attendees, depending on the size of your practice and how you're planning to report your quality measures. I mean, if you are a small practice and you have less than 15 clinicians and you're still using claims as individual reporting, you certainly could report your quality via claims. You can report your improvement activities by direct attestation, and then the cost is based off of administrative claims. So thank you for that.
And this is Morgan. I was
going to mention that with regard to the quality specification sheets, if any of you are sitting in front of your computer, the way you can find those, because they are important to understand, like Candy Newlands mentioned that HCPCS codes and CPT codes, if you went to the qpp.cms.gov, in the very upper portion of the screen you'll see an About. If you click on that, there's a resource library that you can navigate to. And you'll see a screen pop up that has, in big letters, Resource Library. Just below that, there's yet another link to click on for Resource Library. And you'll see prominently displayed Find 2018 resources by provider, by topic on the CMS page that you land on. This is a little bit convoluted, but we can put this in the notes and follow up with you. The next page that you land on, there are various categories, and below that, you'll see a whole bunch of claims registry measures, 001-050, etc. Those are where the specification sheets are buried. So that is a little bit of a lengthy navigation process, but we'll follow up with that.
Thank you, Reed. And this is Holly again. One thing that I also would like to point out is I'm often asked out in the field if you could use the same improvement activities. The short answer to that is yes. If you selected improvement activities for 2017 and then chose to use the same ones for 2018, but you really, really have to be careful, and again, taking a look at making sure, first and foremost, if that improvement activity is still available for this year, because there have been a handful of measures that have been retired for 2018. So, making sure that they're still available, but secondly, ensuring that the specifications for those improvement activities have not changed. There are some measures that it is truly written that you have to have a minimum of, 90 days. Other measures, there are things that you have to do. So just like the quality measures in the specification sheets, understanding what is expected when you are going to be selecting that measure for your MIPS attestation.
And this is Candy, and not only that, there are some improvement activities that have changed their weighting status from last year. So they might have been high last year, but they might have been bumped down to medium for this year. So again, just don't make assumptions about those, and just go ahead and make sure that you're checking into that. There's a couple of activities actually that have a minimum of 6 months. There's one particular activity. It's a training activity that it specifies that you can only do that activity once every 4 years. So again, like Holly said, just, read through it so you clearly understand what you're doing.
This is Lisa. That also applies for the quality measures, of course. They could have changed specifications, and you do want to review each of your quality measures that you choose this year to make sure that the measurements haven't changed, specifications haven't changed, and that they're still available, etc. And we know already that benchmarks have changed. Actually, they changed in late 2017 for the 2017 reporting period. And then they published a new set of benchmarks for 2018, but we aren't sure yet if CMS will change those benchmarks yet again before the end of the year. And it doesn't seem like they've changed a lot. Go ahead.
That kind of begs the question, or underscores the need to use the MIPS estimator. Maybe you want to expand on that.
So yes, the MIPS estimator takes the most current benchmarks that CMS has published, and we keep them up to date pretty quickly. We had them within a week of CMS publishing them last in December. And so if they do change them, we will go ahead and change the benchmarks that get changed throughout the year whenever CMS changes them. So you'll have, if you're using the MIPS estimator, you'll have the most recent data published by CMS.
Thank you, Lisa. Thank you, Reed. Adrian, can you remind our participants on how they can ask a question?
If you have a question, please press star, then 1 on your touch-tone phone. And currently we have no questions.
Thank you, Adrian. And this is Holly again. One of the things I'd also like to point out is for those that are maintaining an EIDM account, CMS has recently sent out notification that the QualityNet site has slightly changed a little bit, especially the secure portal section of it. So there is a drop-down that you'll have to select your type of organization if you're logging into your EIDM account. So just be aware that that has been moved around a little bit. It still is easy to walk through, but when I logged in yesterday, it looked a little different, and then immediately CMS had sent out a notification that they did some updates.
And this is Mona, and I would remind people, if you do not have your EIDM account, that you can get that at any time and sign up for it. And I'll post a link to a document to explain how to do that, kind of a quick start guide to getting an EIDM account. That was probably, at the end of the year, one of the most challenging things for people for reporting is getting that account, and there was some delay. So there's no reason to wait till the end of the year to do that this year.
Another thing, this is Holly again. We also received notification late yesterday that CMS will be hosting 2 back-to-back webinars on Physician Compare. Keep in mind that CMS is considering using the quality payment program scores for clinicians. They will be posted on Physician Compare. And so on July 24th and 26th, and we'll also send this information out, CMS will be hosting 2 webinars, and they're going to be going over the public reporting on Physician Compare. They're also going to be talking about, MIPS and Alternative Payment Models and the information that will be posted there. And then there's going to be a 30-day preview period as well. So we will send out this information in our document, but just wanted to make everybody aware because we are getting a lot of questions about what CMS is going to be posting up on Physician Compare. Right now, it's not finalized, but we've been hearing some talks that it's going to be the overall score for each of the categories for 2017, excluding obviously the cost category. But definitely webinars that, if you want to learn more about this information, we can certainly, help to get that registration link out to you as well.
And as a reminder, if you have a question, please press star, then 1 on your touch-tone phone.
I just received another request for clarification. So it looks like Diane is asking about reporting as a group, and if some of the providers in our group leave during the reporting period, do we still need to count them when we do have to submit data for attestation? So thank you for this, Diane. So there is some clarity on this. Definitely it is beneficial to include the data for those eligible clinicians that are leaving or have left. I believe in Candy or Lisa, if you can remind me, I believe September 1st was the cutoff period, that if your clinician was at your practice prior to September, then it depends on what practice is responsible, if it's the new TIN or the old TIN that has to report. So again, I have to get clarification on this, but there is a specific cutoff period that if the clinician left the old TIN prior to that September cutoff, then the new TIN is responsible for reporting. But if they left after the September cutoff, then the old TIN is expected to report for them. And I know this came up a few times, but just to avoid confusion, especially if you're group reporting, you want to include that clinician that has left your tax ID number, because you don't want to put them in a particular case where their data, they're expecting somebody to submit data on their behalf and no data has gone in, and now they are not passing their MIPS because they've missed, submitting data. So definitely something to keep in mind. But thank you, Diane, for that question.
So this is Lisa, and I'll take that, Candy, and if you have something to add, please do. So if in the case where you have a provider who has been attributed to your tax ID number, CMS has that. So if they have billed to Medicare between January 1st and August 31st, they are associated with your TIN, and therefore if your group is eligible to report, or if they were individually eligible to report, you should at least report one thing for them so they don't get a negative payment adjustment. And whether you include them, if you're reporting as a group, you should report them actually as a group. CMS assumes that you've included them because they've billed to CMS and you're reporting as a group, depending on your timeline that you included last year. This year, you'll have a full year to do that. but you should include them so they aren't left hanging, as I think that was Holly said. And if they've joined after September 1st, you cannot put them in your, as far as we know right now, you cannot add them to your data because they don't have a billable visit of eligibility. So they need to be eligible to report with your TIN. So you can't even report with them unless they've had a billable visit prior to September 1st.
Thank you, Lisa.
And Don is in the queue with a question. Please go ahead.
So this is Don with Health East again. Based upon your last comment there, Candy, as far as if they joined after October through September 1, what happens if you're only reporting 90 days in your 90-day reporting period is October 1 to December 31? You don't report for those providers?
For those improvement activities because the only category is improvement activities and promoting interoperability.
Mm-hmm.
Yeah, you cannot include them if they aren't in your, I guess the eligibility is that they don't have a billable visit prior to September 1st, because the eligibility determination is different than the reporting period.
Okay, so I'm getting a little confused on the difference then.
So the eligibility periods are determined a year prior to, it goes from September 1 of 2016 through August 31st of 2017 as the first snapshot of eligibility for the TIN NPI, and then you have the 2017 through 2018 eligibility determination period with your clinic, and that's what they take those $90,000 and the 200 patient visits is to determine whether they're eligible to report with your TIN. So if they're not eligible to report with your TIN, they're assuming that you're not including them. So if your reporting period is October, November, December for a 3-month period for PI, they can be included because they've had if they were with you prior to that and they have are deemed eligible with your TIN. But if they joined afterward, CMS is not going to give them credit because they weren't eligible.
Okay.
And as a reminder, to ask a question, please press star, then 1 on your touch-tone phone.
Hey, this is Holly again. So another question came in. This is from Tina. She asked at what point is 2015 electronic when that is required to be installed. So when should her practice install 2015 CERT? So Certified EHR Technology. Thank you, Tina. So for 2018, CMS is allowing practices, clinicians, whoever's attesting for MIPS program to still use 2014 Certified EHR Technology. But also, when we come to 2019, and this has been addressed in the IPPS rule, or the proposed rule, that starting on January 1st of 2019, tax ID numbers or clinicians that are attesting to MIPS are required to have 2015 CERT. Now, because that rule is still proposed and we're waiting for final information on that, usually that's the case that we're probably looking at starting January 1st that you would have to have your 2015 Certified EHR Technology installed at your TIN or your practice. But also keep in mind that that potentially can change, but that is how it's sounding right now. And also, too, I'd like to point out that if you are a TIN or practice that is using 2015 cert, that you have the opportunity to receive additional bonus points that can be applied to your final score if you've implemented that. 2015 cert does require having 5 base measures, and so you have you have a total of 2 health information exchange measures rather than 1 health information exchange measure if you're using 2014 EHR technology. So Sandy or Lisa or Reed, I don't know if you have anything to add with that, but as it stands, you can still use your 2014 EHR this year.
Yep. No, Holly, other than you're only eligible for the bonus for 2015 if you use only 2015 cert for the entire performance year.
This is Reed at Stratus Health, and the one thing I would add to that is that some models you have to kind of proactively, or EHRs I should say, you have to proactively go to your vendor, ask about that upgrade pathway to 2015 cert. Others, if you're a web-based, and you're probably aware of that, but you can just rely on your vendor automatically upgrading everybody to 2015 cert version. Everybody kind of moves at the same pace, but that really is dependent on the vendor. So if you're not aware of what the answer is, whether that just happens and when it happens, or whether you need to get in touch with your vendor, I would look into that because of that upcoming January 1st very likely requirement, unless that changes in the final rule. But that would be some advice for you.
This is Lisa at Stratus. I'm going to clarify that the promoting interoperability cert bonus is if you use your cert for the 90 days the full 90 days that you've attested, not a full year. And then
I don't think that's true, Lisa. I think it's the full year, but I could be wrong.
The reporting period is 90 days.
I understand that.
Yep, let's verify that. So yeah. And maybe I'm not understanding that correctly then. So we'll verify it.
You know, flip a coin. One of us might not be understanding that.
So we'll verify that.
Reminder into the queue. Please press star, then 1 on your touch-tone phone. Currently, we have no questions.
If the group wants to have the patients, Reed's probably already on the bonus sheet, on the ACI fact sheet, to clarify whether or not it's a full year or a performance year. So Reed, am I making that assumption incorrectly?
Yes, you are making that assumption incorrectly, only because I'm taking copious notes today.
Oh, that's right. I forgot about that. So, you know, we have 6 minutes left. We certainly could look it up while we're talking.
I'm on the site right now.
Okay, so it'll just take us a minute.
So am I. So looking at it.
All I'm seeing on the site is that in order to receive the bonus is submitting only from PI objectives and measure set and only using 2015 edition cert. It is not specific to a time.
Yep, that's exactly what I'm finding. I have not found anything else either, Lisa. It's just that one statement. This is Mona.
So we can throw that question out to CMS and get back to everyone on that.
Okay, well, I think since we're coming to the top of the hour here, so if there aren't any other questions, I think everybody will appreciate another 4 minutes added onto their day. So I want to thank everybody for joining us. And as mentioned, we will compile and vet these questions that came in today and then email over the information via the email that was registered for the event. And we appreciate everybody attending our office hours. We will be hosting another office hours in July, and so registration link will be sent out, and it's also in our agenda. So our next office hours will be on July 19th, and that'll be from 1 to 2 Eastern or noon to 1 Central Time. And we are anticipating offering office hours for the remainder of the year as well. So thank you again for joining us, and we ask that you please take a moment to complete the brief evaluation that will be appearing when you close out of the webinar. And your feedback is very much appreciated, and it helps to inform future educational offerings. So if there's something that you want us to present on outside of the office hours, just let us know. And we appreciate you attending today. So thank you so much. And Adrian, if there's no other questions in queue, I think we can end the day.
Thank you, ladies and gentlemen. This concludes today's webinar. Thank you for participation. You may now disconnect.